Hi everyone, so I hope I'm live now. So let us begin this session. So this session is going to be about very high yield flashcards, and then I would be making you write the very important topics that you can review for today and tomorrow. All right, so just give a thumbs up if you are able to hear me properly. Am I audible? Are you guys able to hear me properly? All right, okay. So let us begin today's session. So we can see this picture. So this is the flashcard number 1 for today. So what you are seeing here is a cherry red spot on the macula. All right. So this is a cherry red spot on the macula. If you're able to see it. So tell me the condition in which you are going to see the cherry red spot on the macula. Which condition are you going to appreciate this? So you will always have three differentials in your mind whenever you come across this cherry red spot on macula. All right. Exactly, Yash. You gave the right answer. Yes. So number one is the central retinal artery occlusion. Okay. And yes, Manasa, that is the correct answer. The second one is the Niemann-Pick disease, and third one is Tay-Sachs disease. So guys, this differential should always be on your tips. So whenever you come across the term cherry red spot on the macula in the exam, so you will think about these three conditions. Number one, Tay-Sachs disease. Number two, Niemann-Pick disease. Number three is central retinal artery occlusion. Okay. Now I have written the most important points regarding these conditions. Okay. So number one, Tay-Sachs disease. So guys, whenever you talk about the glycogen storage diseases or the lysosomal storage diseases, what you have to remember is which enzyme is deficient, and secondly, which substance is getting accumulated. So these are the two very, very important points that you have to keep in mind. So this comes under clinical biochemistry. Okay, so the deficiency of hexosaminidase, that is seen in case of Tay-Sachs. Okay, so what is getting accumulated? The answer is GM2 ganglioside. All right, so what is getting accumulated? GM2 ganglioside is getting accumulated. And very, very important point, you have to keep this point in mind, that you don't see hepatosplenomegaly in case of Tay-Sachs disease. Why it is important? It's important because it helps you differentiate it from Niemann-Pick disease. So Tay-Sachs and Niemann-Pick, both of them, they are the lysosomal storage diseases. All right, but both of them, they also show the cherry red spot on the macula. So how you gonna differentiate between both these two? Number one, based on the enzyme that is deficient. Number two, based on the substance that is accumulated. And number three, on the basis of the presence or absence of the hepatosplenomegaly. All right. So hepatosplenomegaly is not seen in Tay-Sachs disease, whereas hepatosplenomegaly would be seen in case of Niemann-Pick disease. Okay. So this is very, very high yield point. So mark it. Then in Niemann-Pick disease, whose deficiency is there? Your answer is sphingomyelinase deficiency. So there is going to be sphingomyelinase deficiency in case of Niemann-Pick. And who is going to get accumulated? Your answer is sphingomyelin. Sphingomyelin. And the third differential for a cherry red spot on the macula is central retinal artery occlusion. All right. So know these three very, very high yield differentials of cherry red spot on macula. Now moving on to the second flashcard. Yes. So this flashcard says the keywords that could be given to you in the question. So if the question says that there is failure of the lower esophageal sphincter to relax, okay, so what will you think about? So I'll draw a picture here so that we can better understand this. This is the lower esophageal sphincter. This is esophagus, that is lower esophagus. And after lower esophageal sphincter, we have stomach. All right. Now this lower esophageal sphincter, if it is not relaxing, you will call it, yes, Gurjeet Nipun, yes, Manasa, this is the right answer. The answer is achalasia. Okay. Now, what if I change the statement? What if I change the words in the question? Lower esophageal sphincter tone reduced. So what if the question mentions the LES tone is reduced? What would you think about? So I'll give you one more hint that the patient would come with heartburn. Heartburn, and when you do the examination, when you do the investigations, you on the manometry you will see that the lower esophageal sphincter's tone is reduced. Yes, so the answer here is GRD, gastroesophageal reflux disease. Okay, so these type of patients, they have heartburn. Okay, they have uncomfortable feeling, and they could have dysphagia. Whereas eclasia, this lower esophageal sphincter tone is increased. LES tone is increased because it is not relaxing. All right. So what's going to happen? The food particles, whatever the patient is ingesting, they are having a hard time in reaching the stomach because the lower esophageal sphincter is not relaxing. It is very tight. So the esophagus will start filling with the food products. Okay, and it will be dilated. All right. So what is this characteristic finding that you see in case of eclasia? So let us talk about eclasia. So number 1 point, eclasia can be of two types. It could be primary eclasia or it could be secondary eclasia. Okay, primary means that here the cause is actually unknown. Okay, idiopathic. But secondary, one question is there. Supposing you are being asked which parasitic infection could lead to secondary eclasia. Which organism, which parasite would you mark? Which parasitic infection is associated with secondary eclasia? Anyone? Your answer to this question is going to be yes, Gurjeet. The answer is right. We have Panosoma cruzi infection. Okay, that is Chagas disease. So mark it. This is very, very important. Chagas disease. This could lead to secondary eclasia. Okay, so in Chagas disease, what you remember is we have mega esophagus, mega colon. All right. So these are the things that happen in Chagas disease, and this is due to the Trypanosoma cruzi infection. All right. What are the drugs being used for Chagas disease? What are the two drugs that you prefer for Chagas disease? Yes. We have benzonidazole. We have benzonidazole and nifurtimox. So we have two drugs that could be given for a patient who is having Chagas disease. That is benzonidazole and nifurtimox. All right. So how will you remember these drugs? The easy way to remember these drugs is that a lady wearing a fur coat is traveling in a Mercedes Benz. So this female is wearing a fur coat and she is traveling in a Mercedes Benz. So fur coat means nifurtimox and benzonidazole, that is Mercedes Benz. All right. Now, what is the problem with eclasia? The problem with eclasia is that eclasia is associated with higher risk of esophageal cancer. Okay, so that is why it should be taken very carefully. So eclasia is associated with increased risk of esophageal cancer. Similarly, in the previous lectures, I taught you a condition in which the esophageal epithelial change is there. Okay, one type of epithelium is being replaced by the other epithelium, right? So what is that? That is known as a Barrett esophagus, and Barrett esophagus is associated with increased risk of the adenocarcinoma of the esophagus. All right, so that is also very, very important. Okay, what type of metaplasia takes place in Barrett esophagus? Very high yield. Then again, eclasia, you should know parasitic infection associated with it. And then next, what do you want to see on the imaging test? Okay, so remember we have a finding known as bird beak sign. If you can see here, you would be seeing that there is this dilated part, and ultimately, since the lower esophageal sphincter is not relaxing, it is very tight. So you see this sharp ending here. All right, so this is known as a bird beak sign that you see in case of eclasia. All right, so remember this point. Moving on to the next card. Yes. So what is this? It's written in front of you that you are seeing something known as a strawberry tongue. So supposing you are being given a picture like this, and you are being asked, okay, what could be the possibility? So what are the two major differential diagnoses if you think about this picture? Okay, if a patient is coming to you with this type of presentation. Yes, Gurjeet, Vicky, Vora, Nipun, yes, that is number one, Kawasaki disease. Number two differential, Number two differential? Yes, that is scarlet fever. Okay. Before that, let us discuss what is this strawberry tongue that we are seeing here. Why do you think this, this is resembling a strawberry? This resembles a strawberry because overall the background of the tongue is red tongue. But what you are seeing as these white dots, what are these white dots that you're seeing? Yes. So we have hyperplasia of the papillae on the tongue. Okay, so this is known as a strawberry tongue. So when you talk about a strawberry tongue, the red tongue with the hyperplasia of the papillae, this is a strawberry tongue. And now we have very important differentials for strawberry tongue. Number one is scarlet fever. Number two is Kawasaki disease. Okay, so scarlet fever is associated with which type of infection? Anyone? Scarlet fever is associated with which type of infection? Yes. Which infection is associated with scarlet fever? Your answer is? Which organism is associated in causing scarlet fever, guys? Your answer is group A, Streptococcus. Okay, that is stepped pyogenes. Stepped pyogenes. So remember this. Talking about the next point here. Most likely, in case of Kawasaki and scarlet, in both these conditions, you're gonna get a history of a child. Okay. Then second, the child would be having strawberry tongue. Third thing, scarlet fever, particularly when you talk about it, it is associated with the stepped pyogenes infection. That is the group A streptococcal infection. Then talking about the another presentation of scarlet fever. So what do you see in scarlet fever? That the patient will be having cervical lymphadenopathy. Cervical lymphadenopathy. The cervical lymph nodes will be enlarged. The child will be having sore throat. And very, very important keyword here, sandpaper texture like rash. Okay, sandpaper texture rash. So add one point here. So what if the question, the wording in the question is changed? Okay, sandpaper like texture, rash on the forehead in an elderly male who is a farmer. So guys, see here the history has changed. What has changed? You have changed the age group here, elderly male. Look at the occupation, farmer. Okay, and this elderly male patient is coming to you with a rash, okay, or a lesion on the forehead that gives a sandpaper like texture. So very rough lesion. Okay, so what is this? Gurjeet, sporothrix occurs due to the injury due to a thorn. Okay, sporothrix chensky, that is occurring due to the thorn injury, and ultimately there will be lymphangitis. All right, so this is not sporothrix. This is not sporothrix. That is sporothrix. They will give you most likely the history of a gardener. All right. Here, sandpaper-like texture. So guys, in case of scarlet fever also I told you sandpaper-like texture, but the age group is a child. The patient would be a child. Alright, along with that other manifestations. Here, sandpaper-like texture on the forehead. Then elderly male and farmer. The answer here is going to be actinic keratosis. Actinic keratosis. Why this has to be taken very, it has to be dealt in a very quick way. Why you need to have a good index of suspicion? Yes. Actinic keratosis, if someone is having, number one, the patient would be of advanced stage. And actinic keratosis usually appears on the sun-exposed areas. On the sun-exposed areas. All right. Now, what is the problem with actinic keratosis? The problem here is that actinic keratosis is a pre-malignant condition. Excellent. So, pre-malignant condition. Next question. Actinic keratosis increases the risk of which type of cancer? What is your answer? What is the answer? So the answer here is that actinic keratosis increases the risk of squamous cell carcinoma of the skin. Increases the risk of squamous cell carcinoma of the skin. Guys, skin cancer, they are also very important. Okay, so basal cell carcinoma, squamous cell carcinoma, then melanoma. Melanoma is most important of them. So keep in mind the important points regarding melanoma. What type of mutation is associated? Then the ABCD of the melanoma. What is the important prognostic factor in melanoma? All these things are really important regarding melanoma. All right. So that was a point where I integrated a sandpaper-like texture of the rash. Okay. So if it is a child, you can think about scarlet fever. Elderly male who is involved in an occupation that requires having more sunlight exposure, that is actinic keratosis. Okay. Now another very peculiar feature of scarlet fever. So what if you are given a picture like this? So this is perioral pallor. Okay. So around the mouth area, around the lips area, there is going to be pallor. Otherwise, you see in this picture, there is overall flushing, right? But around the mouth, around this lip area, you will see pallor. This is a very peculiar feature of scarlet fever. Know this, no? Okay. And then again, desquamation of the skin of the hands and feet. That is also a very important feature of scarlet fever. Now, talking about the second differential of strawberry tongue. Okay, so we have Kawasaki disease. Kawasaki disease, number one, the history would be of a child. Number two, very important thing that you have to keep in mind regarding Kawasaki disease. So in order to diagnose Kawasaki disease, the child should have fever for at least 5 days. Okay, so know this because they have this particular points in the diagnosis. Kawasaki disease, the child should have fever for at least 5 days. Then there is going to be desquamation of the skin of the hands and the feet. Then very important, cervical lymphadenopathy is there, but it is particularly unilateral. Only on one side you will be appreciating that the cervical lymph nodes have been enlarged. All right. Then bilateral conjunctivitis without exudate. So that means the patient will have both the eyes which are red. Okay, bilateral conjunctivitis is there, but there won't be any discharge from the eyes. So bilateral red eyes or pinkish eyes you will be appreciating, but the exudate won't be there. So this is the kind of wording that you have to remember in case of Kawasaki disease. So bilateral conjunctivitis without exudate. All right. And then the rash is polymorphous rash. Now let me also tell you a very high-yield word here. So when a child is having Kawasaki disease, what are the treatment options for that? What treatment options would be there? Anyone? What are the treatment options for a child having Kawasaki disease? Yes, Gurjeet, excellent. Okay, so why this is important? Because Kawasaki disease is a very rare indication, of giving aspirin in a child. Okay, so this is very important point. Usually, aspirin should be avoided in a child. Why? Why normally you avoid aspirin? What is the reason? Anyone? Why you normally avoid aspirin in a child? Yes, Gurjeet. The answer here is due to the risk of Reye syndrome. In Reye syndrome, the liver gets damaged, there is encephalopathy. Okay. So what kind of history you are expecting in a patient of Reye syndrome? So I'll tell you a scenario. The child comes with the parents to the OPD and they tell you that this child is having pain abdomen. There is pain abdomen. They have the reports in which LFTs are deranged. All right, the child appears confused and they will give you a history of upper respiratory tract infection few days back. So they will give you a history of upper respiratory tract infection few days back. They will tell you, doctor, my child was having cold few days back or a runny nose, all right? And they will tell you that they gave a drug X. They gave a drug X to the child. Fever was also there, all right? Now the child is complaining of all these things. Now what is this drug X and what is this child likely to have? So this is the kind of history that you could expect in case of Reye syndrome. So the drug is aspirin and the condition is Reye syndrome. Condition is Reye syndrome. All right. So you should always remember that you should not give aspirin in case of a child. Okay. Particularly when a child is having upper respiratory tract infection, because majority of the upper respiratory tract infection in children are viral in etiology. Okay. So you should avoid it. And the take home message is that you can read about the pathophysiology of Reye syndrome, that how aspirin is actually reacting with the virus. Okay, so there is a kind of interaction between the virus and the aspirin, and ultimately few changes take place that leads to the damage to the body. All right. Now, I was talking that Kawasaki is a very rare indication in which you give aspirin to a child. Okay, in fact, high dose aspirin is given. Guys, when you talk about aspirin, aspirin is having different kinds of action. When you talk about aspirin, aspirin is a non-selective NSAID. Non-selective NSAID. That means it is going to inhibit both COX-1 and COX-2. It is going to inhibit both COX-1 and COX-2. COX-1 or COX-2, these are the cyclooxygenase enzymes. All right. Now, aspirin is having additional actions apart from having anti-inflammatory action. How anti-inflammatory action? Because it is inhibiting the cyclooxygenase pathway. So apart from having anti-inflammatory action, aspirin is having antipyretic action. That means it could be given in fever. Then it is also having anti-platelet action, all right. So you might have seen patients who are being put on the low dose aspirin if they are at increased risk of getting an MI, all right. So pre-existing patients who have this coronary artery disease, right, they are being put on the low dose aspirin. Now you could be asked, okay, what is the reason of the antiplatelet action of aspirin? What confers the antiplatelet action to aspirin? Okay. Yes, Guruji. The answer is aspirin inhibits thromboxane A2. So inhibition of thromboxane A2. So mark this point. This is associated with the antiplatelet action of aspirin. That is why aspirin is having antiplatelet action. All right. So these three actions, they are dose dependent. So you can read about it. Okay, different doses of aspirin will produce different effects. All right. Coming back. Moving on to the next flashcard. Yes. So look here. What if you are given in a question the continuous machine-like murmur? This is very high yield, very commonly asked. Continuous machine-like murmur. What will you answer? So everyone would be knowing this. So type in, think about it and type the answer. Okay. I'm waiting for others. Exactly. So you guys already know it, that this is the patent ductus arteriosus. Patent ductus arteriosus. But just knowing that this is PDA is not enough, obviously. Okay, so we should understand what is this PDA and what would be the effect of this PDA. So let us draw the four chambers of the heart. So you should always draw the heart in this way so that the things are clear in your mind. So this is right atrium, this is right ventricle, then this is left atrium, this is left ventricle. All right. The blood enters the heart via right atrium. From the right atrium, the blood goes into the right ventricle. But here, I will talk about fetal versus the adult or post-birth circulation. Okay, so here we will compare what are the differences of a circulation in case of a fetus and that of the situation after birth. So both these things are different. So normally what happens, this is of post-birth situation. Okay, blood enters the right atrium, then into the right ventricle. Here we have a valve known as tricuspid valve. That is why you call tricuspid valve as a right-sided valve. Now from the right ventricle, the blood goes into the pulmonary artery. This is pulmonary artery. All right, and then here we have pulmonary valve. Pulmonary valve. Now from the pulmonary artery, the blood goes into the lungs. The blood goes into the lungs. From the lungs, after getting the oxygenation, okay, the function here is that blood will get oxygenated in the lungs. What type of blood is there in the right atrium? Deoxygenated. Deoxygenated blood is there in the right atrium. Now this deoxygenated blood, once it enters the lungs, it will get oxygenated and ultimately via pulmonary veins. Via pulmonary veins, this oxygenated blood will now reach the left atrium, and from the left atrium, the blood goes into the left ventricle via which valve? Via which valve? Which valve is present between left atrium and left ventricle? Anyone? Which valve is present between left atrium and left ventricle? Exactly. Yes. So you guys gave the right answer. The answer is mitral valve. Here we have mitral valve. All right. Via the mitral valve, the blood from the left atrium will enter the left ventricle, and ultimately from the left ventricle, the blood goes into aorta. Aorta. And here we have aortic valve. Aortic valve. Okay. And via the aorta, the blood is going into the systemic circulation. So throughout the body, the blood is distributed from the aorta. Okay. So systemic circulation. So this is what happens in normal people, like after birth. This is the circulation. Now I'll draw one more picture here. Again, we will draw the four chambers of the heart. If you remember this in the fashion that I'm telling you here, you will never forget it. So this is right atrium, right ventricle, left atrium, and left ventricle. All right. Now, when the fetus is in utero, okay, when the baby is not born and it is in utero, what happens is the lungs are bypassed. So this is pulmonary artery. The lungs actually, they are not functional. They are not expanding. So nature has found a way in which you can bypass the lungs. Okay. So what happens is, while the blood goes from the right atrium to the right ventricle and from right ventricle to the pulmonary artery, instead of this blood reaching the lungs, the blood directly goes into aorta. The blood directly goes into aorta, and hence these lungs, they are getting bypassed. Okay. So what is this connection? So we have this fetal connection. We have this fetal connection between the main pulmonary artery and the aorta. Okay, this fetal connection between the main pulmonary artery and the aorta is known as ductus arteriosus. This is known as ductus arteriosus. Okay, so know this point. Now, what happens is that there are a few factors that keep this ductus arteriosus patent while the baby is in utero. Okay, when the baby is there in the uterus, there are few things that keep this ductus arteriosus open so that the lungs could be bypassed. Number one is low oxygen tension. Number two is prostaglandins. Prostaglandins. These are the factors that keep the ductus arteriosus open. Okay, this could be a confusing point, so you always remember it. The factors that keep it open: low oxygen tension and prostaglandin. Now, after birth, This ductus arteriosus, this closes, this obliterates. Okay, can you tell me the structure that is being formed due to this obliterated ductus arteriosus? This is very, very high yield point. Structure formed by the obliterated ductus arteriosus. Anyone? Which structure is formed by the obliterated ductus arteriosus? Yes, guys. So let me see who can answer this. The structure formed by the obliteration of the ductus arteriosus after birth. The answer to this question is ligamentum arteriosum. Alright. So, see here. We have something known as patent ductus arteriosus. Patent means open. So, after birth, if ductus arteriosus is not closing, you call it patent ductus arteriosus. Okay. And this is a picture that is showing you the patent ductus arteriosus. If you can see, this is the pulmonary artery. This is the aorta. And they have shown this connection, this abnormal connection between the pulmonary artery and the aorta. Okay. So this is known as the patent ductus arteriosus. Obviously, we are talking about after birth scenario. Okay. Not when the fetus is in utero. So this is PDA. Now PDA, as I told you before that, ductus arteriosus, as I told you, that this is the connection between the main pulmonary artery and the aorta. Why this happens? To bypass the lungs. Okay, normally the ductus arteriosus is going to obliterate after birth and it becomes a ligamentum arteriosum. So guys, mark this point. This is very, very high yield. Okay, what is being formed due to the obliteration of the ductus arteriosus? Your answer is going to be ligamentum arteriosum. Alright. Now, if ductus arteriosus persists after birth, you will call it patent ductus arteriosus. This also I told you. Okay, what are the factors that keep the ductus arteriosus open while the baby is in utero? The number one is low oxygen tension and prostaglandins. All right. Now, after you diagnose this condition after the birth of the baby, if the ductus arteriosus is still open, so what are you going to do in that situation? What do you want to do in that situation? Which drugs you could use in order to close the ductus arteriosus before the surgical repair? Okay, what medications you could use to close it? Exactly. So you guys are correct. Indomethacin or ibuprofen could also be used. Okay, what is indomethacin or ibuprofen? What is indomethacin or ibuprofen? What are these drugs? These drugs are NSAIDs, non-steroidal anti-inflammatory drugs. Excellent. And as you know that NSAIDs, they are inhibiting cyclooxygenase. And if they inhibit cyclooxygenase, whose production or whose synthesis is going to be reduced? Anyone? The answer is prostaglandin. So this is what I have written here. Indomethacin or ibuprofen, they are going to inhibit the prostaglandin synthesis and ultimately it will help in the closure of the patent ductus arteriosus. Okay. So the take-home message regarding PDA is number one, continuous machine-like murmur. Number two, that the factors that could keep the ductus arteriosus open while the baby is in utero is low oxygen tension and the prostaglandin. Then if you want to close it, you can give the NSAIDs which inhibit the prostaglandin synthesis like indomethacin, ibuprofen. Alright. Now guys, indomethacin, I'll add one point here. So supposing in the question they write a few points in the history like a young male coming to you with lower back stiffness, that gets better with activity, Yes, what you can think about? A young male complaining of lower back stiffness, getting better with activity. Anyone? This kind of history. Yes, I don't want to give you one more hint, otherwise you will be able to easily diagnose it. Yes, so Ramayana, Nipun, Madhavan, Sai. You gave the correct answer. This is a typical history of ankylosing spondylitis patient. Okay, which HLA is associated with ankylosing spondylitis? Which HLA is associated with ankylosing spondylitis? Yes, Your answer is HLA B27. Okay. Yes, Gurji, that is the right answer. HLA B27 association. Okay. What happens to RA factor in case of ankylosing spondylitis? Is RA factor positive in ankylosing spondylitis? Anyone? Yes. So RA factor is negative in case of ankylosing spondylitis. That is why you call it seronegative spondyloarthropathy. Seronegative spondyloarthropathy. Alright, but what is positive here? HLA B27 association. Then very high yield point regarding ankylosing spondylitis. Sacroiliitis. Yes, Madhavan, you gave the right answer. Sacroiliitis. Okay, so this is very, very important. So you should always be able to document the sacroiliitis either on the X-ray or on the MR. Okay, so this is very important. If sacroiliitis is not there, the likelihood of ankylosing spondylitis is very less. So sacroiliitis is a very important component of diagnosis of ankylosing spondylitis. Then we have bamboo spine. Yes, we have bamboo spine. So there is bony ankylosis, okay, in the vertebrae, and this gives the appearance of bamboo spine. All right. Okay. Now, the purpose of me telling you regarding ankylosing spondylitis is that we have a drug of choice for ankylosing spondylitis. What is the first preference that you would think about in case of treatment of a patient of ankylosing spondylitis? What is the first thing that comes in your mind? The drug of choice is indomethacin. Yes, indomethacin. This is the reason why I integrated it here, because indomethacin, as we were using it to close the PDA, indomethacin is also the drug of choice for ankylosing spondylitis patients. All right, so know this. All right, in India, Indocap that is commonly used, that is having indomethacin. All right, so for ankylosing spondylitis patients, we have this. Now, guys, seronegative spondyloarthropathy, we don't just have ankylosing spondylitis. Can you give me an example of other seronegative spondyloarthropathies? Seronegative spondyloarthropathies. Yes, number one we have is ankylosing spondylitis. Number two, psoriatic arthritis. Psoriatic arthritis. So what is that deformity in the hands that you appreciate in case of psoriatic arthritis? What is typical? Yes? Commonly asked question. Psoriatic arthritis. What is the deformity? What appearance in X-ray you see? Pencil and cup. Okay, so know this. You can read about psoriatic arthritis. Moving on to the third seronegative spondyloarthropathy, we have reactive arthritis. Reactive arthritis. So guys, reactive arthritis, why do you call it reactive arthritis? The reason is that this arthritis, that is the joint inflammation, this occurs as a result of reaction to something. Okay, so supposing someone comes to you, the kind of history that you get in case of a patient who is having reactive arthritis is that the patient comes to the OPD with joint pains, and they are going to give you a history of an antecedent abdominal infection, GI infection, or a GU infection, genitourinary infection. Okay, so either the patient will give you a history that the patient was having UTI, or there could be some history of gastritis. All right, so this type of history is given in case of reactive arthritis. And there are different organisms that are implicated in causing reactive arthritis. Can you tell me the organism associated with reactive arthritis? Anyone? Organisms associated with the reactive arthritis. Just one example. Yes. Good, Shigella. Then, okay, Campylobacter. Good. All right. So you can read about, yes, chlamydia, very important, chlamydia. Okay, so chlamydia trachomatis is also implicated in causing the reactive arthritis, Yersinia also, Yersinia. All right, and the last point regarding the seronegative spondyloarthropathy, that is inflammatory bowel disease associated arthritis. Okay, so the patient could be having a history of Crohn's disease or ulcerative colitis, and ultimately the patient is developing joint pain. Okay, so this is IBD associated arthritis, and that is a part of seronegative spondyloarthropathy. Okay, now moving on to the next flashcard. So look here. So what if in the question you are given this type of history? Failure of lactation, cold intolerance, absence of menstruation in a postpartum female. So the kind of history in which the female gave a birth to the baby, and ultimately after some time she'll complain of failure of lactation. She is not able to feed her baby. She is feeling extremely cold. Okay, she is not able to tolerate the cold environment. Then she is not having menses, and ultimately all these symptoms. So here we are talking about a condition known as, Gurjeet, what do you call it? Exactly. So this has been asked several times. So know this, guys. This is Sheehan syndrome. This is Sheehan syndrome. Okay, so this is very important. Sheehan syndrome is also known as the postpartum ischemic necrosis of the pituitary. All right. So let us talk about it. So we have Sheehan syndrome, that is postpartum ischemic necrosis of the pituitary gland. Right. Now, let me explain you a few points about Sheehan so that we can have a better idea. Why do you think this female is having this type of presentation? Now, what happens is during pregnancy, the body has to prepare itself, right? The body has to prepare itself for the different kind of events. So you read about the physiological changes that take place in the pregnancy. Okay. Now, as you know that there would be need for lactation, there would be need for the milk production for feeding the baby, right? So during pregnancy, the changes take place in the body, and which hormone would be actually helpful in lactation, in milk production? Which hormone is having a crucial role in the milk production? Yes, the answer is prolactin. Okay, so that means the body has to increase the prolactin levels. Okay, and ultimately, if prolactin is there, milk production will be there, and once the baby is sucking the breast, there will be milk leg down reflex. Okay, that takes place under the influence of oxytocin, and ultimately there will be lactation. Okay, so the baby would be fed. Now, in order to increase the prolactin, what changes take place in the body? So from where is prolactin coming? Anyone? So we all know that Sheehan syndrome means pituitary necrosis, okay, postpartum. But why this happens? You should also understand this. So from where is prolactin coming? Remember, prolactin is the hormone that is coming from anterior pituitary. Okay, anterior pituitary. So this is basic physiology that you should at least know the hormones coming from anterior pituitary and the hormones coming from posterior pituitary. This is just the basic physiology. So you are required to know this. Okay, so anterior pituitary hormones. Number 1, prolactin. Number 2, ACTH. Number 3, LH. Number 4, FSH. Number 5, growth hormone. Number 6, TSH. Number 6, TSH. These are all anterior pituitary hormones. When you talk about posterior pituitary, we have 2, ADH and oxytocin. ADH and oxytocin. These are the posterior pituitary hormones. Okay, now since prolactin is coming from anterior pituitary, obviously in order to increase the synthesis and the release of prolactin, there would be increase in the size of pituitary gland. Increase in the size of pituitary gland. Why? Because obviously there will be hyperplasia in the pituitary gland because we want more prolactin. So overall, the size of the pituitary gland during pregnancy is drastically increased. During pregnancy, it is drastically increased. Okay. Now, what happens? Supposing this female gives birth to the baby, and while the baby is being born, okay, the baby comes out, but the placenta is still inside the uterus, and you see that the uterus is not contracting properly. So contraction of the uterus is very important in order to expel the placenta. Okay. So what is the situation that I'm talking about? The uterus is not contracting. So the placenta is not coming out. What is the situation that we are talking about? Anyone? So here we are talking about the uterine atony. Uterine atony. Uterine atony means the tone of the uterus is low. The uterus is not contracting. So guys, after the birth of the baby, it's very important for the uterus to contract. What is the reason? Why do you want the uterus to contract? Anyone? Why do you want the uterus to contract? Number one, expulsion of placenta. Expulsion of placenta. Number two, if the uterus is contracting, the blood vessels which are denuded, the raw blood vessels that are lying there, once the placenta is separated, the blood vessels, they are being torn or they are raw. Okay, so if uterus is contracting, those blood vessels would be constricted. And obviously, if a blood vessel is constricted, the blood loss will be less. So in order to limit the blood loss, uterine contractions after the birth of the baby, they are very important. Right? Now, if uterus gets tired, if uterus is not contracting, that is uterine atony, this is the most common cause of. So this is also a question that has been asked several times, guys. What is the most common cause of PPH? Okay, postpartum hemorrhage. So what is the most common cause of PPH? Your answer is uterine atony. Excessive blood loss during the childbirth. Okay, so that is PPH. Now, another point here. Supposing this female gets PPH, there is excessive blood loss after the birth of the baby, right? So what could happen? As I told you that during pregnancy, the size of the pituitary is drastically increased. Supposing this is sella turcica. So pituitary is sitting in sella turcica. This is normal anatomy. So this is pituitary gland. This is enlarged. Okay, this is enlarged. So obviously, if a structure is enlarging, the blood supply would also be more in order to support that. So during pregnancy, the blood supply to the pituitary is also more. So that more prolactin is going to be released. More blood supply to the pituitary. Now, what happens is, when PPH happens, a lot of blood loss takes place. A lot of blood loss takes place. If blood is getting lost excessively, pituitary obviously, which was having high demand, would not be getting enough blood because blood is getting lost because the patient is having PPH, right? So what would happen here is that the pituitary will have reduced blood supply, that is known as ischemia. Ischemia means reduced blood supply. So there will be postpartum ischemia of the pituitary. Postpartum ischemia of the pituitary. Now guys, it's very clear that imagine if ischemia is prolonged, ultimately the result is necrosis. That is why you call Sheehan syndrome as a postpartum ischemic necrosis of the pituitary gland. All right. So this is the reason why the patient who is having PPH is at increased risk of getting Sheehan syndrome, because during pregnancy the size of the pituitary is increased drastically in order to increase the prolactin release, and ultimately the blood supply to the pituitary is also high. But if the female is losing blood during childbirth, excessive blood loss is there, pituitary won't be getting enough blood supply, and ultimately there will be ischemic necrosis on the pituitary. Okay, so what does that mean? That means that whatever things were coming from pituitary, the pituitary hormones will suffer. Okay, the pituitary will become now dysfunctional. So this is the reason why in this flashcard I included this type of history. Failure of lactation. What is the reason of failure of lactation in Sheehan? Now you guys will answer. Failure of lactation in Sheehan. What is the reason for that? This is the one of the first presentation of a patient having Sheehan syndrome, guys. Failure of lactation. But why does that take place? What is the reason? Anyone? The reason is that, as I told you, the pituitary will become dysfunctional. Prolactin won't be coming out. Okay? Prolactin is gone. So that is why lactation is failing. Then cold intolerance. Okay? Because TSH is also coming from anterior pituitary. So that is why cold intolerance. Okay? Absence of menstruation, LH and FSH, they are also coming from anterior pituitary. Right? So these are the things that you have to keep in mind regarding Sheehan syndrome, because pituitary is losing its function. Okay? So know these points. Okay. And when you do the imaging, what will you see is empty sella turcica. Because pituitary sits in the sella turcica. Okay, that is a depression and in which pituitary is fitting in. But now you see in case of the Sheehan syndrome, the pituitary is actually not getting blood supply. So there is ischemia and ultimately necrosis. The pituitary is becoming very small. There is necrosis. So you will see an empty sella turcica on the brain imaging. All right. Moving on to the next flashcard. Yes. So look here. What if you are given this type of history? Dryness in the eyes, xerostomia, joint pain, dry nose, dry cough, and dry vagina. Anyone? So Tejaswar, I will ask someone from the Unacademy to post the PDF of the classes here also, and on my Telegram group also I posted the PDFs. Yes. So this is Sjogren syndrome. Okay. Xerostomia means dry eyes. Sorry, dry mouth. Dry mouth. Xerostomia means dry mouth. Okay, so dryness in the eyes, dryness in the mouth, joint pain, then dry nose, dry cough, and dry vagina. This is a typical history of a patient having Sjogren syndrome. Now let us talk about Sjogren syndrome, the high yield points. Okay, Sjogren syndrome, number one. What type of autoantibodies are you expecting to be positive in case of Sjogren syndrome? What kind of autoantibodies? The answer to this question is anti-Rho or SSA and anti-La or SSB. So if you see these type of antibodies being present, okay, if they write these type of antibodies, they are present in the question, you will think about Sjogren syndrome. Second important thing regarding Sjogren syndrome. So in Sjogren syndrome, what happens is all the secretions, okay, be it lacrimal secretion, salivary secretion, they are reduced. That is why you see a lot of dryness, be it in the eyes, be it in the mouth or the dry vagina, all right? So there's a test that you do in order to evaluate the tear production. So this has been asked several times, so mark it. Schimmer's test. Okay, so this is important. Schimmer's test. What is Schimmer's test? This is the test to evaluate the tear production in a patient. Okay, so what you're going to do is you take a filter paper strip and you put it on the lower eyelid. And once you put this filter paper strip on the lower eyelid, obviously, if the tear production is there, this will get wet. Okay? And if the wetting is more than 15 mm after 5 minutes, this is normal. This happens in a normal person. But if someone is having Sjogren syndrome, the filter paper strip, the wetting that you see in that would be less than 5 mm. That would be less than 5 mm. And that is typical in case of Sjogren syndrome. Okay, so this is very, very important. Keep this in mind. Okay, now, okay, so someone is asking for a Telegram link. That is by my name, Dr. Simran Kaur. I'm typing it. Okay. Next question that has been asked several times, be it in IB and ICTs also. Which is the best site to take biopsy in case of Sjogren syndrome? Which is the best site to take the biopsy in case of Sjogren syndrome? Anyone? Yes? Which is the best side? Okay, you said salivary gland. Any specific answer? Yes, your answer is labial salivary glands. Okay, so know this. This has been asked several times. So mark it, labial salivary glands. They are the best site to take biopsy in case of Sjogren syndrome. Okay. Now look at this question. The patient coming to you and saying you, doctor, I have the worst headache of my life. Worst headache of my life. What is this? Anyone? Exactly. So this is SAH. SAH is subarachnoid hemorrhage. SAH is subarachnoid hemorrhage. Alright? So know this point. Subarachnoid hemorrhage. Okay, one question here. What is the most common cause of non-traumatic subarachnoid hemorrhage? Non-traumatic subarachnoid hemorrhage. Yes, Madhavan, that is the right answer. So the cause of non-traumatic subarachnoid hemorrhage is rupture of berry aneurysms. Berry aneurysms. Which type of patients are more prone to get berry aneurysms? Which type of patients they are more prone to get the berry aneurysms? Anyone? The answer to this question is hypertensive patients. Hypertensive patients. Okay, so in the history you could be given a hypertensive male who was not consistent in taking the medications, ultimately developed the aneurysm, that is berry aneurysm, and when that ruptures, that could lead to subarachnoid hemorrhage. And the history that is being given in case of subarachnoid hemorrhage is thunderclap headache or worst headache of patient's life. All right, moving on. Yes. So what if the question mentions waxing and waning lymphadenopathy? What if the question mentions waxing and waning lymphadenopathy? What would you mark? Waxing and waning lymphadenopathy means the lymphadenopathy is coming and then again vanishing, then again lymphadenopathy is there, then again it resolves. So what type of history, what type of condition are you expecting with this type of history? Anyone? Yes? Waxing and waning lymphadenopathy. If any question mentions this wording, or if any question mentions that the patient is having lymphadenopathy recurrently, and then it spontaneously resolves, and then again patient is having lymphadenopathy, this is the typical history that you see in case of follicular lymphoma. Gurji, that is the right answer. Follicular lymphoma. Okay, so know this point. Waxing and waning lymphadenopathy seen in case of follicular lymphoma. All right. Similarly, if I give you a history of a jaw mass in an African child, jaw mass in an African child, what is the condition that we are talking about? Jaw mass in an African child? Yes. The condition is Burkitt lymphoma. Sai, you gave the right answer. Burkitt lymphoma. Okay. Burkitt lymphoma is associated with a virus. What is that? What is the association of Burkitt lymphoma? Anyone? Yes. Epstein-Barr virus. Okay, so another lymphoma that is associated with EBV. So if EBV plus HIV, you will think about primary CNS lymphoma. Primary CNS lymphoma. Okay, know this point. Burkitt lymphoma also associated with EBV. One more thing, painless cervical lymphadenopathy in a child. Painless cervical lymphadenopathy in a child plus EBV association. This is Hodgkin lymphoma. Hodgkin lymphoma. So see, you should always remember the cancers that are associated with EBV infection. They are very, very important. In one of the lecture here on YouTube, I have taught you the infective etiology is associated with the different type of cancers. For example, the HHV8, okay, human herpes virus 8, that has been associated and implicated in causing what cancer? HHV8. Anyone? The answer to this question is Kaposi sarcoma. And Kaposi sarcoma, guys, that is a vascular malignancy, okay, that is arising from the vascular endothelial cells. And obviously, Kaposi is not just limited to the skin, it could be happening anywhere in the body. So, visceral involvement is very common in Kaposi sarcoma. And a very important differential diagnosis of Kaposi sarcoma is bacillary angiomatosis. And Kaposi sarcoma mostly commonly occurs in the patients who have HIV or immunosuppressed patients. All right. Moving on. Yes, so Madhavan, infectious mononucleosis also is associated with EBV, that is a kissing disease. But here we were talking about the cancers, no? We were talking about the cancers, all right? Otherwise, so we have this hairy leukemia also, oral hairy leukoplakia, sorry, that is also associated with the EBV, right? Okay. What if the question mentions waxing and waning consciousness and decreased span of attention? Waxing and waning consciousness means the patient, supposing I give you a history here, patient is hospitalized. Patient is hospitalized. Patient is having waxing and waning consciousness. That means the patient is gaining consciousness and then losing consciousness time and again. And patient is not able to be attentive enough. Okay, mental status is altered. And the patient is having long-standing, poorly controlled diabetes. Long-standing, poorly controlled diabetes. What is the answer here? Excellent, Gurjeet. The answer to this question is delirium. Delirium. Guys, whenever the question mentions waxing and waning consciousness, you will think about delirium. The typical history that is given in case of delirium is hospitalized patient having long-standing metabolic condition. Most commonly it occurs as a result of metabolic conditions, for example, diabetes. Very common association with diabetes or any other endocrinopathy. Okay. All right. Now, moving on to the next flashcard. So look here. Patient is having hemorrhage, then diabetes mellitus, nystagmus, that is to and fro motion of the eyeballs, then hypertrophic cardiomyopathy. What is this history pointing towards? What is this history pointing towards? What do you think it is? Anyone? So hematos, diabetes mellitus, nystagmus, hypertrophic cardiomyopathy. Let me see who can answer this question. Anyone? Yes. Gurjeet, you gave the right answer. The answer here is Friedreich ataxia. Friedreich ataxia. So this is very important, guys. Know this. So here we are talking about Friedreich ataxia. So this is one of the trinucleotide repeat expansion condition, which is associated with GAA repeat expansion in the frataxin gene, that is FXN gene, on the chromosome 9. Okay, here I need to integrate a table that should be on your tips. So the trinucleotide repeat expansion conditions, they are very, very high yield. Know these, guys, very important. Okay, be it any exam. So if the question mentions CAG repeats, if the question is mentioning CAG repeats, your answer is going to be Huntington disease. Huntington disease. Okay. If the question mentions CGG, then the answer is going to be Fragile X. Fragile X. If the question mentions CTG repeats, your answer is going to be myotonic dystrophy. So paste it on your wall. This is very important. Okay. Then GAA repeats, Friedreich ataxia. GAA repeats, Friedreich ataxia. Okay. All right. Moving on to the next flashcard. So what if this history is given to you in the question? Bilateral hilar lymphadenopathy, then cough, arthritis, erythema nodosum, and uveitis. What is this pointing towards? Anyone? What is this pointing towards? Anyone? Yes. So Ramin gave the right answer. Okay, that is sarcoidosis. So guys, one thing is very clear that whenever you see bilateral hilar lymphadenopathy, you should always think about sarcoidosis. So we have hilar. Okay, when you look at the chest X-ray, we have hilar present on both the sides, right and left. And if the hilar lymph nodes, they are enlarged on both the sides, okay, that would be visible, apparent on the chest X-ray. You will first of all think about sarcoidosis, and the patient is having cough, arthritis, erythema nodosum, and uveitis. How they can explain erythema nodosum? Obviously, they are not going to directly write erythema nodosum present, okay, because that is going to be a very important hint for that, although it is a non-specific finding. So they could write painful tender. They could write painful tender subcutaneous nodules on both the shins. Okay, so on both the legs, okay, on the anterior surface, you will see that the patient would be having tender nodules. So when you touch those, the patient will be having pain, and this is pointing towards the erythema nodosum. All right, and then the patient having uveitis. Now, this is the typical history for sarcoidosis. So, I have written the keywords for sarcoidosis here. So, number one, what type of granulomas do you expect in sarcoidosis? Your answer is non-caseating granulomas. Non-caseating granulomas. Number two, what happens to the ACE levels in sarcoidosis? Your answer is increased ACE levels. Okay, increased ACE levels. Number three, what happens to serum calcium levels in sarcoidosis? Increase serum calcium. What happens to serum vitamin D levels? Increase. Now, the question that could be asked to you is why serum calcium levels are increased in sarcoidosis. What is the reason that sarcoidosis patients, they have increased serum calcium? Anyone? What is the reason why sarcoidosis patients have increased serum calcium levels? Can anyone answer this question? Yes? Anyone? All right, I'll explain this to you. Yes, Gurjeet, you gave the right answer. So, in case of sarcoidosis, the macrophages which are activated, they have 1-alpha hydroxylase. They have 1-alpha hydroxylase activity. Okay. For that, you need to have basic concept regarding 1-alpha hydroxylase. See, 1-alpha hydroxylase activity, this is usually being present in the cells of PCT. In the cells of proximal convoluted tubule, there is activity of this enzyme known as 1-alpha hydroxylase. What is the action of this enzyme? 1-alpha hydroxylase converts calcidiol into calcitriol. So calcidiol is the inactive form of vitamin D, whereas calcitriol, that is the active form of vitamin D. That is the active form of vitamin D. So that means 1-alpha hydroxylase is having very important action in activating the vitamin D, and hence vitamin D would perform its action, right? What is the action of vitamin D? Increase calcium and phosphate absorption from the gut. Increase calcium and phosphate absorption from the gut. This is the reason why vitamin D increases the serum calcium levels also, okay? Now what happens in sarcoidosis is that the macrophages which are activated, you know that what are the components of a granuloma, right? Granuloma is formed of macrophages, then epithelioid cells, which are the activated or modified macrophages, and the multinucleated giant cells. So activated macrophages in case of sarcoidosis, they express this enzyme 1-alpha hydroxylase. This is not the normal location of 1-alpha hydroxylase activity. The normal is PCT cells. But here macrophages also express this enzyme. So what is going to happen? Just a second. Yes. So I was talking that what the macrophages are going to do, they are going to also express the 1-alpha hydroxylase. So obviously calcidiol is going to get converted into calcitriol. So more vitamin D is equal to more absorption of calcium from the gut, and ultimately the patient is going to have increase in the serum calcium levels. Okay, so this is the point that you have to remember in case of sarcoidosis, that why serum calcium levels are increased in sarcoidosis. All right. So that was all about today's class, and Unacademy is having new offers. Okay, so there's a final booster batch that is for NEET PG, so they have this offer, and then there is upcoming batch for the next. Okay, so they are giving it for 19,000, so you can get this, and then they have this crack FMGE 23 with the FMG mastery course. Okay, so all the top-notch teachers are there, so you can go ahead with these batches, right? And I'll see you guys tomorrow. I hope you like this lecture. I'll see you tomorrow. Bye bye.